Welcome everybody. This is Walk with the Doc, August 2018. A beautiful day. We dodged those floods and rains. I hope you guys are all set at home. It's been a crazy couple of weeks, but we got a good morning for our walk today. Our speaker today is Dr. Robert Akbari, a colorectal surgeon at Doylestown Health. He's our third speaker to have a close connection to Doylestown in Bucks County, having grown up here. He's going to introduce himself and then give you an idea of what he does for a living.
All right. Don't mind me if I put my hand up a little bit here and there. The sun's in my eyes, but thank you, Jim. I'm happy to be here. I don't know, maybe it was a month ago, I was walking by. Thank you. And got snagged by the ladies here as I was walking by, and we were talking about how it was a nice day and whatnot, and then they asked me if I wanted to do this, and I said I'd be happy to. So I am from the area originally. You know, it's just some background on myself. I grew up on first Pine Run Road, and then near CB East off Hollycong Road. I went to Doyle Elementary, and then I transferred to Our Lady of Mount Carmel. Went there, and then I went to LaSalle for high school. So I went to my mom's a Catholic. I was raised Catholic, and I was once I was on the wait list. They didn't tell me I was on the wait list at Mount Carmel. All of a sudden, one day I came home. My grandmother, my mom, congratulated me for getting into Catholic school. I didn't realize I had applied, and there I went. In terms of, you know, my parents were both actually workers here at Doylestown. My father was a urologist. He's retired now. He's a snowbird, as is my mother. They had a nursing here eventually. You know, and I was a pre-med volunteer. You know, the program, I just spoke to them actually earlier this week. Dr. Schaefer still runs it, and he did run it back then when I was a college student. But anyway, in terms of, I just wanted to give some background on my specialty. It's not a specialty many people think about much, and maybe you don't realize that it actually exists as a specialty. It's not a glamour field, as some of my mentors used to say. You know, it's not plastic surgery or whatnot. People often ask me when they're in the office, what made you go into this field? And usually my answer is, do you want the funny answer or the serious answer? And and usually they want the funny answers first. And my funny answers change over time. One of my funny answers is that I was at the bottom of my medical school class. Another one is I have a poor sense of smell, and that's anyway, we won't get into that. In terms of serious answers, that changes depending on my mood. But usually my serious answer, to be honest with you, and to distill it, is basically that I know that most people that walk into my office, I can help. So they can walk out happy, or after the procedure that I recommend, they can walk out happy. So most things in my world you can fix, and that includes everything from hemorrhoids or anal fissures or itchiness of that area, what we call pruritus ani, to something as serious as colon cancer, rectal cancer, Crohn's disease, etc., and everything in between. In terms of my specialty, colon and rectal surgery, it's funny. I don't know if you guys ever listen to sports radio, but there's an ad that's on every so often saying, I think it's Lowell Meyerson, Dr. Lowell Meyerson, the only board-certified proctologist in the state of Pennsylvania. And it sounds like a monster truck commercial because the voice is like, but technically that's true. Proctology is no longer an official field. The American Board of Proctology was founded in something like 1899 or 1898. And basically what you did back then was you went to medical school, and then you did a year of training in proctology, and then you're off to your job. So it was 1 year of proctology, and it was mainly anal issues, you know, not doing major abdominal surgery or things like that. It was dealing with hemorrhoids, etc., down below, and that's what proctology is. Then in the 1950s, it morphed as a field. A person who did it, and actually he's one of my mentors, a guy called Stanley Goldberg in Minneapolis. He did a general surgery, 5 years of general surgery training, and then did 1 year of proctology residency. And then him and a group of other like-minded individuals decided to form or to change basically proctology into a new field, which is colon and rectal surgery, which covers proctology but also intestinal ailments in the abdomen. So basically it became a subdivision or specialty under the umbrella of general surgery. So you did general surgery training for 5 years after medical school. Then you do pretty much a year, only a year, because you get a lot of that stuff while you're a general surgery resident. And then you're a full-fledged colorectal surgeon. That's what I did. I bounced around the country. I went to medical school at Hershey, Penn State and Hershey. Did my general surgery in Pittsburgh at a place called Western Pennsylvania Hospital. I did a year of research and learning how to do endorectal ultrasound at Sloan Kettering in New York, and then I did a year of proctology, here I'm stumbling on my own words, colorectal surgery at Minneapolis St. Paul, which is, and then I went to Baltimore, which is where my wife grew up and practiced there for many years, and then about 4.5 years ago, I came back to Doylestown. I knew that Dr. Sinnott had worked here years ago as a colorectal surgeon, was away went to Lehigh for 10 years, and basically they didn't have a colorectal presence here at the hospital. And one thing led to another, and here I am. So it's been going well for me. You know, I do every facet, and I have a new partner I'm excited about who just walked by and is going around right now. His name's Christopher Bruce, and he is seasoned. He's been in practice for a long time at Suburban down in the Norristown area, and we managed to recruit him, and he's here full time. So it's me and him, where our office is 2 blocks away. But again, in terms of, I was just driving in terms of what to talk about. I'm not honing in on any particular topic, but I had to admit a lot of people recently are asking me about Cologuard. There's lots of ads about that. I just heard an ad on it when I was driving in, and a lot of patients are asking me about it. And it's an interesting thing because I think the way it's promoted in advertising is you know, they're trying to promote their product, but it almost gives you the impression that you don't need a colonoscopy anymore. That you get a Cologuard, you know, once a year or what have you, and that's it. You don't need any other tests. And that is not the case, just to emphasize that to you. Cologuard certainly is a step up from fecal occult blood testing. So, you know, fecal occult blood testing is less accurate than is Cologuard for sure. And if Cologuard comes back positive, because it's checking for DNA cancer, colon cancer DNA in your stool is basically what it's testing for. If it comes back positive, the odds are that you probably do have a colon cancer, and it's that accurate. That being said, you know, it's not 100% accurate for one thing. There are false positives, and you know, if it's negative, it doesn't mean you don't have a cancer. So you still need the colonoscopy starting at age 50 or younger, depending on family history, but usually starting at age 50, and then every 5 to 10 years, or even 3 years if you have polyps on your prior one. You know, until when? Some people say age 80. There's no perfect answer there. It depends on your functional status at that age and things like that. And if you've had a lot of negative, meaning no findings, colonoscopies between age 50 and age 80, probably smart to stop it, because colonoscopy is not a risk-free. It is invasive. It's not a risk-free procedure. So that's just one thing to bring up, is the Cologuard idea. It's a great, I think, it replacing fecal occult blood testing or hemoccult testing is sort of, I think that's where its place is, but its place is not to replace, as far as I can tell, colonoscopy. It doesn't, the other thing is, you have to remember, colonoscopy does not, it doesn't only diagnose colon cancer or colon polyps, it also prevents colon cancer. It's therapeutic. You can go in there and remove polyps, and in doing so prevent a colon cancer from forming. And since I'm talking about screening right now, I'll talk a little bit about the other screening. What are the alternatives to colonoscopy for screening? Well, there's what's called virtual colonoscopy. Some of you may have heard of it. It's a CT colonography is another way to say it. It's basically a CAT scan, a fancy CAT scan. So unlike a regular CAT scan where you don't have a bowel prep beforehand, this time around you have the nasty stuff the day before, like you do for the colonoscopy, cleans your system out, then you go to the CAT scan area, then they put a tube in your rectum, wide awake, you're wide awake, not asleep, and they inflate your colon with air to stretch it out so that the details of the lining of the colon are more visible on the CAT scan. And then they run you through the CAT scanner in thinner slices. And that's what a virtual colonoscopy is. It's a way of detecting polyps short of colonoscopy. The nice thing about virtual colonoscopy, I mean, the best thing is that there's no incidence of colon perforation. Colonoscopy does have a risk, a very low risk, less than 1 in 1,000 of rupturing your colon, and that's a big deal situation, obviously. That doesn't happen as far as I can tell with virtual colonoscopy. The downside of it is it's not quite as accurate at finding polyps less than 0.5 centimeters in size, although those are usually benign. And also you're awake during the whole thing, so you still have to go through the prep and you're awake. So it's not the most comfortable thing to undergo. And lastly, it's not therapeutic. So if they find a polyp is found during virtual colonoscopy, it cannot be removed with it. You have to undergo a true colonoscopy after that to remove the polyp. In terms of recommendations for virtual, it's every 5 years instead of every 10 years, the national guidelines. And those are the two main screening methods that are acceptable. In Medicare patients, and I'm guessing a lot of you are Medicare, but I won't, they don't push back because there's no pre-certification, so usually you can order a virtual if you have Medicare. If you're private insurance, a lot of times they push back. They prefer to pay for a colonoscopy to a virtual. I guess it's cheaper. And the only reasons are the main in private insured patients. They'll cover it if you do a colonoscopy. If I do a colonoscopy on someone and I can't get through an area for whatever reason, it's a twist in the colon or whatnot, then oftentimes they'll approve it. But if it's a person walking off the street and you order a virtual, a lot of times they'll push back. And I think it is a cost issue. So that's some background on screening. In terms of colon cancer itself, it's the second most common cancer in the USA for both men and women, equal to in men and women. It's not partial to one gender or the other. It's the third leading cause of death in men and women from cancer-related death in the USA. So it's something that doesn't make for great dinner conversation. People love talking about other parts of the body and not that part. But it is important. I mean, when I was in training, there was something, I don't know if it ever came to this area, but there was something called the colossal colon. It was touring the Mall of America. It was going around the country. And it was sort of like the Franklin Institute, where you walk through the heart, but you're walking through the colon. And you see polyps, what polyps look like, and it's sort of interesting. Kids like it. But they actually, the Mall of America refused to have it in the central area near the food court. So it wound up going in the parking lot. It was the summertime,
He saved my life after a ruptured appendix.
I appreciate it. Thank you.